All right, so let's build on what we learned in parts 1 and 2 of chapter 19 as we get into chapter 19, part 3. So in this section, we'll be talking about the cardiac cycle. So let's talk specifically about pressures and flow, and also the phases of the cardiac cycle. And then we'll get into some information about heart sounds. I'll ask you to bring a stethoscope to class if you happen to have one. If you don't, that's okay. We'll have some in the lab that you can practice with. So to start off here, let's talk about the overview of the cardiac cycle. So as you can see here, this gives you a full cycle of the cardiac cycle, which begins in atrial systole and progresses to ventricular systole, then atrial diastole, and then ventricular diastole. So some of the things to kind of keep in mind from what we learned in AMP1 and then earlier in AMP2 is that we know blood flows from areas of high pressure to areas of low pressure. When an area of the heart is under systole, this area is now under high pressure, and blood flows into an area of low pressure at that point, which we call diastole. So in terms of the phases of the cardiac cycle, each heartbeat is followed by a brief resting phase, which allows time for the chambers to relax and prepare for the next heartbeat and for oxygenated blood to be distributed to the wall of the heart. This period between the start of one heartbeat and the beginning of the next is called the cardiac cycle. All right, so here you can see you have the phases. Number one, when the cycle begins, all four chambers are relaxed. For part 2, in atrial systole, we have the contracting of the aorta, fill the relaxed ventricles with the blood. Then we have the atrial diastole, which is the concurrent part with the ventricular systole. That occurs in 2 phases. And then the first phase of ventricular systole, you have the contracting ventricles push the AV valves close, but not providing enough pressure to open the semilunar valves. And then you have the ventricular pressure now equal to the systemic pressure. You can see here the ventricular systole second phase is as the ventricular pressure continues to rise, the semilunar valves open and blood leaves the ventricle. And then we have the ventricular diastole, the early and late parts, which encompass steps 6 and 7, and you can read through those there as well. So a couple points I'd like to make here is that although we think of the heart as a pump, it's really 4 pumps that work in pairs. And therefore, a heartbeat, as you can see, is a very complicated event. The 2 aorta contract first, pushing the blood into the ventricles, and then the 2 ventricles contract, pushing blood through the pulmonary and systemic circuits and into the aorta again. Okay, once again, when the process begins, all 4 chambers are relaxed, and then the same process is followed. So for any one chamber in the heart, we can say that the cardiac cycle is divided into 2 phases, and we know those are called systole and diastole. Another word for systole is contraction. And another word for diastole is relaxation. So I would suggest, and I kind of keep scrolling back and forth between the 2 slides, because I would suggest studying this and trying to commit it to memory to the best you can. All right, use the image here to help you visually see what it is that the phases of the cardiac cycle involve. So I'm a big proponent in really trying to show things in multiple ways. So some of you may have a better understanding of the cardiac cycle if you look at it in terms of a strip here. So basically what we just talked about is shown in this strip. You can see that the process starts with all 4 chambers being relaxed, and then we're going to have atrial systole occur, which is when the atria contracts, completely filling the relaxed ventricles with some blood. And then atrial systole ends and atrial diastole begins. And it continues until the start of the next cardiac cycle, So you can see the ending of one cycle here, and then once again, the start of the new cycle here. Okay, looking at this in terms of the specific waves, we can see that the P wave here at the very start of the cycle represents the depolarization of the atria. It's followed by atrial contraction, which we know is part of the systole phase here. Then atrial systole extends until the QRS complex, which we learned about, at which point the atria becomes relaxed. So this is the part that represents depolarization of the ventricles. And then we have that followed by ventricular contraction. And then when we get to the T wave here, the final part, that represents the repolarization of the ventricles and marks the beginning of ventricular relaxation, also known as ventricular diastole. And then once again, we go back to the starting point when we get here. So when we're using our stethoscope, how exactly do we place it for auscultation? Well, there are 4 heart sounds that are produced as a result of the cardiac cycle we just discussed. We have the S1, S2, S3, and S4 sounds. So if we're listening to our own heart with the stethoscope, we would be auscultating our own heart. If we're listening to a patient's heart with the stethoscope, we'd be auscultating their heart. We should clearly be able to hear the first and the second heart sounds. So the S1 that I mentioned is called, does anybody know? It's called the lub. And it lasts a little longer than the second sound. The second sound, S2, is called the dup. So we have the lub and the dup. S2 corresponds to the semilunar valves that are closed during ventricular relaxation. Now, if you hear a third or a fourth heart sound, that is indicative typically of a certain pathology. For the purpose of our class, we're going to really just focus on S1 and S2. But if your major is nursing or a related field, you're going to be required to detect all 4 heart sounds as part of your curriculum. If we have abnormal heart sounds, we call them arrhythmias. There are certain tests we can use in the hospital or clinic setting to gauge whether we're getting normal or abnormal heart sounds. So we have specialized electronic stethoscopes that allow us to do a phonocardiogram or an auscultogram. So we may also, when we're listening to heart sounds, hear a murmur. So if we hear a murmur, the definition of that, it's basically an unusual sound that's coming from the heart, and it's caused by a turbulent flow or backflow, we can say, of blood. And the murmurs are graded on a scale of 1, which is a more common murmur, not very severe at all, versus a 6, which is a very severe murmur. And murmurs are typically heard in both the S1 and S2 phases. So in lab, we'll have a chance to auscultate specific valves. You can see on this slide here, you have the aortic valve, the pulmonary valve, the tricuspid valve, and the mitral valve. So you definitely want to know the locations of those. So here's a little bit more information on the heart sounds as they relate to the cardiac cycle. And you can see where the lub and dup occurs. Now let's talk a little bit more about heart physiology. So we have a term that we're going to be using called cardiac output. Basically, this is the amount of blood that's pumped from the left ventricle in 1 minute. It's the best overall indicator, really, of peripheral blood flow to our vital tissues. So it's going to depend on 2 factors. The first factor is our heart rate, which is the number of beats that our heart is having per minute. We know that's established by the cardiac conduction system that we talked about earlier. And then the second factor is the stroke volume. So a lot of times you'll see heart rate abbreviated HR, and you'll see stroke volume abbreviated SV. So what is the stroke volume? It's the amount of blood that's pumped out of the ventricle during a single heartbeat. So if we multiply someone's heart rate times their stroke volume, we'll be able to derive their cardiac output. So what factors influence someone's cardiac output? Well, there's a number of factors, as you can see here, that influence their heart rate and their stroke volume, which will in turn, of course, influence the product, the cardiac output. Okay, so just try to commit some of these things to memory. What factors could affect our heart rate? Well, definitely our autonomic innervation. All right, so we know that our body has a series of autonomic functions. We have a sympathetic and parasympathetic nervous system. The sympathetic kicks into overdrive as we wait for the parasympathetic to respond. We could have an elevation in our heart rate. Hormones can affect heart rate. Our fitness level, if we're sedentary versus if we're very active or a high-level athlete, we're going to have differences in heart rate. Typically, high-level athletes tend to have lower heart rates. All right, and it's not uncommon for a high-level athlete to have a heart rate of like 48 or 50 beats per minute. And also, finally, age is going to be a big factor in affecting heart rate. So you probably know that the younger we are, the higher our heart rate typically tends to be. The older we are, the lower our heart rate typically tends to be. And then we have factors affecting stroke volume, which we can see. Those are heart size, our fitness level, once again, gender, contractility, duration of contraction, preload and afterload, which we haven't discussed yet. All right, so again, just try to do your best to commit these things to memory. That way you're aware of these different factors that one can encounter that could affect their overall cardiac output. Okay, so here's a little bit more on the autonomic innervation of the heart. You can see that the vagus nerve, as it is with many things, it's very involved. It's a parasympathetic nerve, and it's going to help decrease the heart rate after the sympathetic cardiac nerves increase the heart rate. So sympathetic comes first, that information is going to the brain, and then the vagus nerves can act in a parasympathetic manner to decrease the heart rate. So what's normal in terms of heart rate? We probably should talk a little bit more about that because these are potential questions for a test. So the American Heart Association considers the homeostatic range for resting heart rates to be about 120 beats per minute for a newborn, and for an adult, somewhere in the range of 60 to 100 beats per minute. And again, that's going to vary based on the adult. The low end of that and even below that can be normal, can be considered within a person's normal if they're a high-level athlete. The maximum heart rate average range is 200 to 220 beats per minute. All right, and abnormalities in the heart rate, a couple things that are important to know that I'll just verbalize real quick, are bradycardia, which is a condition in which the heart rate is slower than normal. So essentially, if someone is brady, they have a heart rate of less than 60 beats per minute. And tachycardia is a condition in which the heart rate is faster than normal. So if someone has tachycardia, they have a heart rate greater than 100 beats per minute. And again, those are the metrics that they use for those are the adult heart rate normal range. So 60 to 100 being normal, once again. So anything below 60 will be considered bradycardia. Anything above 100 would be considered tachycardia. And as far as the test strips go here, it's important for you to look at these and be able to say that, oh, you know, this here shows a normal heart rate. Why? Because there's a normal level of depolarization. All right, as that widens here, we have a slower depolarization, and that would tell us, ooh, there's a parasympathetic response and the heart rate is decreasing. And then finally, if you notice a lesser amount of space between the heartbeats, you can see that, oh, that's a faster depolarization. Things are occurring much quicker. And so we call that a sympathetic response and an increased heart rate. All right, so there's more heartbeats here. This is normal. There's much less heartbeats here. Okay, so once again, normal, much less. That's parasympathetic, heart rate decrease. Much more sympathetic, heart rate increase. So if you were to get 3 pictures in lab, you'd want to be able to distinguish which one is normal, which one is showing a heart rate decrease, and which is showing a heart rate increase. And likewise, which would be the parasympathetic and which would be the sympathetic responses. So these are the open stacks slides that we're following, but I do want to add something in here before I kind of get into the factors affecting stroke volume. I just want to mention a couple of things that I think are important to know that kind of bring us back to our study of the nervous system in AMP1. So you might be wondering how one's heart rate can just kind of fluctuate so much throughout the day, right? And we can say basically that our heart rate can be altered by the autonomic activities that are occurring inside the cardiovascular centers located within our bodies. And remember, the reflex center that really controls this is the medulla, also known as the medulla oblongata, as we talked about in AMP1. So these centers, this medulla oblongata, which is a big part of the reticular activating system, is going to innervate the heart by means of what we call the cardiac plexus. And what will happen is the cardiovascular reflex center, which is located within the medulla, is going to receive input from various receptors. And those receptors are proprioceptors, they're baroreceptors, they're chemoreceptors, there are other stimuli that's received from the limbic system. Limbic system is going to regulate our emotions. And together, these inputs are going to regulate the heart function. All right, so precisely we call that our cardiac reflexes. So what will happen is we'll have this cardio-inhibitory center, and then we'll have this cardio-acceleratory center right within the medulla. And so what's important to know is that the sympathetic neurons that increase the heart rate are occurring in the cardio-acceleratory center, and then the parasympathetic neurons that slow the heart rate are all accomplished via the vagus nerve, cranial nerve 10, and that occurs in the cardio-inhibitory center of the medulla. So once again, you have sort of this sympathetic and parasympathetic nervous system playing off each other, receiving various inputs from a variety of receptors to regulate these higher brain functions to essentially control the heart rate. And then we can't forget from our study of the endocrine system at the very end of AMP1 that there are a number of other factors that can have an impact on our heart rate. And the chart in an earlier slide kind of mentioned this. We talked a little about hormones. All right, we know epinephrine, norepinephrine, and our thyroid hormones can have an impact on heart rate. All right, we talked about that in our previous course. The levels of various ions like our calcium, our potassium, our sodium, which channels are opening, which are not, body temperature, our pH balance, all those things are heart rate impacting. So now I'll get into the factors that influence overall stroke volume. So we have this term called preload, and that's basically the amount of myocardial stretch that permits these ventricles to fill. All right, the afterload, which you see here, is the amount of tension the contracting ventricle needs to produce to force the semilunar valves open to essentially eject the blood. And the contractility, the middle column, refers to the amount of force that's produced during an actual contraction. So a good way to kind of summarize this, I think, as you kind of look through the chart, is when you have an increase in contractility, something that occurs here, what that's going to yield is a lesser afterload and a greater overall stroke volume. If you have lesser contractility, that will usually produce a greater afterload and a lower stroke volume. So in AMP1, we talked about drugs, and many drugs are used in clinical practice. So we have something called beta blockers, and we have something else called calcium channel blockers. And they can work to decrease contractility. All right, because remember, a drug, hormone, or neurotransmitter of any sort can accomplish something in the body, right? It can block or it can mimic. And so what happens is with the beta blockers and calcium channel blockers, we are decreasing what you see here. Okay, so it's blocking these types of things. So this is interesting. Fetal shunts basically are these small little passages that direct blood flow that needs to be oxygenated. And so basically these shunts are going to bypass certain body parts as the fetus is still developing in the womb. All right, just from a high level, it's important to know that. I'm not going to quiz you on exactly which ones are developing and what's being bypassed or anything like that. Just know that that's the purpose of the fetal shunts. Okay, so what are some defects that could be congenital? So, well, we have something called ASD, which is the failure of the foramen ovule to close at birth. Okay, we have something called coarctation of the aorta, which is a congenital abnormal narrowing of the aorta. We have something called the patent ductus areosus, which is a congenital condition in which the ductus areosus fails to close. And then finally, we have something called the tetralogy of Fallot, which is also a congenital condition that may occur from exposure to unknown environmental factors. All right, so basically the term tetralogy is derived from 4 components of the condition. All right, one component is pulmonary stenosis, another is an overriding aorta, ventricular septal defect, and right ventricular hypertrophy. Okay, and again, that's called the tetralogy of Fallot. Now, here are some more common ones that could appear in a test that you might be a little more familiar with than the congenital heart defects. These are some additional pathologies of the cardiovascular system. Okay, so take a minute to look at these. You may want to look some of these up. I'm going to give you some brief explanations here. Angina pectoris, okay, pectoris we know is part of the chest from AMP1, okay, and so angina is pain, so chest pain related to coronary problems would be angina pectoris. We have atherosclerosis, which is plaque buildup within the vessels. Okay, some other ones that I want you to be aware of are cardiac shock, which is pump failure. So that occurs when the heart is so inefficient that it can't sustain adequate circulation. So that's really common in a heart attack. In medical terms, it's a myocardial infarction, or also with CHF, which stands for congestive heart failure. All right, then we have myocardial infarction, which is listed here, which is a heart attack. We also have something called sepsis, which I did not list here, but sepsis is a widespread pathogenic infection of the tissues. All right, so if harmful staph starts to invade the body, the bloodstream, and infect tissues all over, that can turn into sepsis. So again, sepsis is a widespread infection of the tissues. And then we have something called septicemia, which also isn't located here. Septicemia is septicemia, and that's a widespread infection of the blood. So again, sepsis, widespread pathogenic infection of the tissues. Septicemia, widespread pathogenic infection of the blood. Okay, we don't have time to cover all these, although we did cover some of these in previous slides. So ischemia is an inadequate blood supply to an organ or a part of the body. Hypoxia is very similar. It's the absence of enough oxygen in the tissues to sustain the bodily functions. And that concludes the lecture on Chapter 19, Part 3.